Good morning and welcome everyone to this meeting. Turned out to be a lovely day today after a rather tough weekend for some of us, not for me. We're revisiting a report that came out from the National Cancer Policy Forum about 2 years ago. Really work that began 3 years ago with a series of 3 workshops, and that's the title. And it did make a strong impact at a time when people were trying to evaluate the efficacy and the efficiency of clinical trials. So I thought I would just summarize some of the main points that were made. They're not the exact points that are in the document. There's a copy of it outside if you want to see it. The first point was that clinical trials make tremendous contributions. And there's a section of that report that's about 20 pages. It just reviews all of the standard of care contributions that were made through a cooperative group clinical trials. However, there was general agreement, and incidentally, this panel and the people that spoke to the panel included stakeholders from every aspect of clinical trial development, academicians and people from the pharmaceutical companies, regulatory, patient advocacy, business, the people that make the machines that make the, and the people that develop the algorithms that we use in informatics and people like that. It was felt that we must, both at the level of the NCI and the cooperative groups, become more efficient and streamlined and much more rigorous in prioritization. The second point, and that just lists some of the advocates there and stakeholders, the second point was that we had to collaborate much more in implementing our recommendations. The third point was that the clinical trials, and this is something that becomes even more obvious today, must have increased emphasis on innovative design and the use of biomarkers, which include lab tests and imaging, in order to target therapy to individual patients, and what we often call now personalized medicine, or there are a number of eponyms. The fourth was recommendations in the direction of the regulatory agencies to balance benefits and risks for people with advanced cancer who are probably willing to take more risks and should be allowed to, leading to earlier targeted approvals for specific groups of patients with rigorous post-marketing surveillance. The power to do that was available to the FDA, but the amount of activity in that direction was modest. And the fifth point was that reimbursement was woefully inadequate. We're going to go into that today. The average patient put on a trial, the physician and the institution carrying that out was receiving $2,000, and the cost was estimated to be much closer to $6,000. And a strong plea that the non-experimental costs of care for patients on clinical trials should be paid for by third party. Medicare does have that in place. It's hit or miss with many of the insurance companies, but many of them are coming around with this in mind. The follow-up today is the second such meeting. The first was soon after this was released, and the second meeting today is going to go into the progress we've made and the suggestions and changes that we might envision based on the Accountable Health Care Act and on other things that we've learned along the way. The scene always changes. So I'm going to turn it over to our chair and thank her and the committee for the hard work they did putting this program together, and thank you all for joining us.